$774.8 billion. That is the projected 10-year reduction in Medicaid spending from a single proposed federal rule. Today, we are walking through CMS-2449-P and why it may be the most consequential Medicaid regulation in decades. Let us start with what state-directed payments actually are, because most coverage of this rule skips the mechanics and goes straight to the politics. In Medicaid managed care, states normally let health plans negotiate rates with providers. SDPs are the exception. They allow states to direct exactly what a managed care plan pays a specific provider or class of providers. The original rationale was narrow: backstop safety net hospitals, push quality-based payment, support delivery reform. But over time, states discovered something important about the financing geometry. Pair an SDP with an intergovernmental transfer or a provider tax, and you can route significant federal match dollars to providers without spending general fund money. A hospital sends $10 million to the state. The state draws federal match and sends back roughly $20 million through the SDP. The hospital nets $10 million that is mostly federal money. The state general fund ends the day flat. That mechanism scaled fast. 2 states submitted 4 SDP preprints in 2016. By 2024, 41 states had submitted 366 preprints. Total SDP spending hit $97.8 billion in fiscal year 2024, and actuaries projected it would nearly triple to $295.9 billion by 2034 without intervention. So what does this rule actually do? The core move is replacing the old payment ceiling with a Medicare benchmark. The prior ceiling was set at 100% of the average commercial rate, the ACR. Commercial rates at hospitals frequently run 150 to 200% of Medicare or higher. The new ceiling is 100% of total published Medicare for states that expanded Medicaid, 110% for non-expansion states, and the state plan rate for any service that has no Medicare equivalent. That switch from ACR to Medicare is not a minor adjustment. It removes the structural headroom that made high-dollar SDPs possible, and CMS goes further than the statute required. The statutory mandate from Section 71116 of the Working Families Tax Cut applied only to 4 service categories in managed care. The proposed rule extends the Medicare benchmark to all SDPs, all services, all states including territories, and creates a parallel limit for fee-for-service targeted practitioner payments under a brand new regulatory provision. The effective date for the broader expansion is the first rating period on or after January 1, 2029. On top of that, the rule eliminates uniform increase SDPs starting January 1, 2028. Uniform increases, where a state directs a plan to give every provider in a class the same dollar or percentage bump, were the primary tool for scaling SDP programs quickly. Removing them significantly limits how states can structure future programs. There is a grandfathering window, but it is narrow. Only preprints completed before July 4, 2025, covering rating periods within 180 business days of enactment, qualify. Grandfathered programs then phase down at 10 percentage points of their total dollar amount per year, starting January 1, 2028. Even programs that make it through that gate are on a defined glide path to sunset. The 10-year savings range runs from just over $400 billion on the low end to just under $1 trillion on the high end. The medium scenario, the headline $774.8 billion, reflects CMS assumptions about how states will adapt and how much SDP growth would have occurred without the rule. The range is wide because state behavioral responses are genuinely hard to model. For health systems and safety net hospitals, the exposure is direct. For states, the loss of a zero-cost federal leverage tool reshapes Medicaid financing strategy. For managed care organizations, actuarial assumptions, network adequacy standards, and rate negotiations are all built on a world where SDP-inflated payments were a baseline. That world is changing. We are just scratching the surface here. The full analysis covers the grandfathering eligibility maze, the gray area payment questions CMS is asking commenters to address, the FFS side of the rule, and the net impact on specific provider categories once you separate gross savings from redistribution effects. Subscribe to On Healthcare for the full paid analysis. Link is below. Subscribe to www.onhealthcare.tech for free and paid articles, podcasts, and more. For a further deep dive on the topic from today's video teaser, see the podcast and article link in the comments.